Whenever we are. Great. Welcome everyone to House Healthcare. It is Wednesday, March 13th. So this morning we're going to have two conversations. We're going to start with H741, and since Ledge Council was able to join us and she was working bright early this morning, she has an unedited draft based on our conversation yesterday over in the pavilion. So we're going to walk through that, and then we can have a discussion about next steps or questions or other witnesses we need to hear from. And then if we have time, we're going to move on to just a committee discussion on the psychiatric residential treatment facility. Okay.
Good morning, Jen Carvey from the Office of Legislative Counsel, and I will share my screen. So yes, I was not able to join you yesterday for H741, but I watched the YouTube this morning and tried to reflect your conversations and questions, and also in one case, something that came up during our original walkthrough. So this is H741. As the chair said, it's not edited. So once I have it edited, I will send it to Zane for posting. But this is an act relating to health insurance coverage for colorectal cancer screening. And so the first thing I did was to change physician to clinician throughout, because that's a good point. Trying to do some more of that throughout the statute. So then I have highlighted what is changed from the bill as introduced. So the next change here is that I know there's a question, I think actually a good question from Representative Peterson when we were doing the walkthrough about what is average risk. And since we are defining or describing what is high risk, I thought it was more accurate to say for an insured who is not at high risk, here's what it is. And then for an insured who is a high risk. So that way you can tell who's who. And then we'd be following the recommendations, the published recommendations established by the U.S. Preventive Services Task Force. And they do use the phrase average risk individual, so I'll use it down here. But when we're talking about our universe of people, we'll use high risk and not high risk. And then, whoops, I forgot to highlight this, but another physician to clinician. And then we have what it means to be at high risk in the existing law. And again, physician to clinician. And then same thing, another change here from physician to clinician. And that's it. I know you heard one request to push out the effective date. I've been in contact with DVA and DFR. I haven't heard back from DVA yet, I don't think, although I haven't checked email recently. But my thinking is if the issue is about plan design and the insurers have been following the ACA federal law requirements around following the U.S. Preventive Services Task Force recommendations already, that seems like it should be baked into the plan design, in which case I'm not sure they would need an additional year to change the plan design. So for at least for now, we've left it as January 1st, 2025.
Any questions on the language based on what we heard yesterday?
Was there any changes to the statement of purpose?
We don't change the statement of purpose. The statement of purpose is statement of purpose of the bill as introduced. And so once the bill has been introduced, when we do a strike all, we don't change the statement of purpose. So this is just the lead-in language saying, so you don't have it online?
No, I know. I guess maybe I'm looking at the wrong bill. I don't see it online.
It's not online. I have not sent this in. You will not see this on your email.
No, I was looking at the previous version. Yeah. Mine says statement of purpose.
Bill as introduced, right? It says statement of purpose of bill as introduced.
Yes.
There is only a statement of purpose when the bill is introduced. When the bill is amended, there is no new statement of purpose. It's just a statement of purpose.
The whole thing about the American Cancer Society.
Yeah, that reflected the bill as introduced, and we don't do a new statement of purpose at each stage of the bill. It's just as it's introduced.
So sorry, we're having a conversation here because I missed the end of the testimony yesterday where Jill was speaking on behalf of VMS. Did you watch it that far?
I did briefly.
Okay, so it's something about. Oh, Jill's here. Hi. Hi, sorry, if you don't mind, you can just from there, but I'm going to ask you a question, then if you introduce yourself. So something about the ages?
Yeah.
Yeah.
Eliminate.
Jill somehow there
Society. So for us, it was making the statute age agnostic, so taking out the age and just tying it to the screening recommendation.
And that's what it does.
We did, right? Okay,
That's what the bill has introduced and this one does.
okay.
Taking out the 50 years of age and even the timing aspects and just tying it to whether somebody is at high risk, not at high risk. And if they're not at high risk, you follow the U.S. Preventive Services Task Force recommendations, which are based on age, but may change. And so this would incorporate any changes they make.
Great. So then go ahead, Leslie.
Well, I have a question not about specifically, more general for Jen. Yeah, okay. We are looking at breast cancer screening also. Is there any opportunity to combine them?
I would,
I mean, what do you
No,
mean?
not do that? I mean, just do one bill?
I do not want to combine. Because I think we're gonna have testimony in the breast cancer bill, so let's wait to hear that. And then we can decide, but at this point, no.
Okay.
And I will say that this bill is effectively codifying federal law. The breast screening bill is not.
Okay.
It's different.
And this has no state. What is it called?
It says no state defrail. They should have no state defrail because it is not making any change to the existing practice under the plans. And you'll hear,
And
yes.
changing from American Cancer Society to the US Preventative, I think helps that. Great. Art?
And this, again, Lori, is more a question for you, maybe, Jen, but I think it's important. Who does this apply to? Again, is that piece that only we,
Yes,
okay, so
yes.
the average, and you've got company insurance with a private thing, it doesn't apply.
Well, it may through the federal law because this is the same standard as under the federal law. And I'll look to Sebastian on this piece. There are certain aspects of what is required under the federal law that apply to the self-funded insurance plans because the federal law can regulate them, even though the state law cannot. And so I believe colorectal cancer screening and the alignment with the U.S. Preventive Services Task Force is one of those provisions that applies to self-funded plans through the federal law. So what we're doing here in Vermont doesn't affect them, but they've already been affected.
Okay, what we're doing here doesn't affect them because they're already,
Because they're already required to do it.
okay,
Yes, not true on a lot of the things we work on, but in this case.
in this case, yeah, okay.
Really, we're just aligning our statute with federal statute is what we're trying to do.
Right, which really, as I think Sebastian mentioned yesterday, is really having the statute reflect what is already happening because the federal law is overriding the state law right now.
So my question, and Sebastian, I might be putting you on the spot here, so I apologize, but my question, I was confused yesterday around non-invasive colorectal screening, so like the Cologuard, I guess is what it's called. That comes back as positive. So now you go to your doctor and need a colonoscopy. Is that colonoscopy still considered screening?
Yes. So what the federal
I'm sorry, can you introduce yourself?
Sebastian Rego for the Department of Financial Regulation. What the federal guidance says is that quote, the U.S. Preventive Services Task Force recognizes the benefits of screening can only be fully achieved when follow-up of abnormal screening test results is performed. So under both the ACA and under the department's reading of the Vermont statute, follow-up screenings following inconclusive or abnormal results are also covered without any member cost sharing.
Okay, great, thank you. Because I know the sponsor of the bill had asked for an amendment for us to put that in, but it doesn't sound like we have to. So, okay. Great, thank you, Jen.
Yes. Few more minutes.
Yeah, so this, we're just gonna open it up for discussion. What do people think? Is this something we want to move? We won't vote on it today because we haven't warned that we're voting. Is it something we want to move?
Yes.
It's pretty straightforward.
Is there a reason not to? No.
It doesn't sound like there's a cost to
There's
it.
no cost, right? DFR and Blue Cross Blue Shield would have told us there was a cost.
You know, Seems good to me.
Yeah.
It seemed like Blue Cross is already doing that, right?
Yeah.
That was my.
Yeah,
interpretation.
they were in full support, so.
I think yesterday, one of the comments made was, and we did this a lot, when I came in 2017 for a couple years, where we codified some things in state law in case the ACA goes away. And so this, I believe, would be one of those.
I have an amendment, though. The amendment is when you have a colonoscopy, they have to revise the stuff they make you drink.
Right. You can make it better. You like this stuff?
Oh, my.
There are different preparations. You
Uh,
may have had a different experience,
Oh,
different.
Let's not go into this.
Yeah.
You may, there are different things you can.
One with Barbie and Jim in it.
So, oh geez. So, all right, so we're gonna move this. I'm gonna leave it to Zane and Claire to connect with you, Jen, on time. You could be here, so I guess you don't have to be here for us to take a vote.
No, but I'm probably gonna be here on other stuff, and so maybe we can.
Okay, so let's coordinate that and we'll make sure we put it on the agenda that it's a vote. So we give people plenty of time if anyone else wants to come forward. So great, that was quick and easy. All right, so we're gonna switch to talking about the psychiatric residential treatment facility. So this is what we talked about yesterday over in the pavilion. So if you remember, this was a budget request. It was in the DEVA budget. We put it, I don't think I have my little spreadsheet. We did not accept, it was in the governor's recommend in the budget request under DEVA, and that's okay. And we said no at the time because we wanted to take more testimony. I think we heard a lot yesterday. I want us to take more testimony, but I also want to get a pulse on where we are on the budget request, because myself and Daisy and Melanie as the budget liaison folks are going to appropriations tomorrow morning. So if we can come to some agreement, we don't need to, I don't need to do this, but I would like to be able to say to appropriations, we're leaning towards yes, we're leaning towards no. I think a lot of the questions we have, at least in my eyes, are to educate us about how the decision was made and how the PRTF is going to work and coordinate bringing kids, youth in. And it might lead us to adding some language to the budget so that we can put some intent in. I did yesterday get an email, and I have not read it yet, so I've not sent it to all of you yet, but I will, from Human Services, who basically said, here's some language we have already put in our budget letter that we really think applies to the PRTF. So if you move forward with it, we want you to put this language in. So the decision is ours at this point. If it's something we want to say, yes, it was in the governor's recommend, and yes, it is something that we think the state needs. So I just want to have a conversation, kind of get a feel where we're going. What's that?
Oh, Leslie.
Leslie.
Oh,
Go ahead, Leslie, go.
Okay, so obviously I heard this whole thing on Zoom.
Right.
And I didn't really get the context, but now I get the context. So I just want to clarify and make
Sure.
sure I understand. So general funds, 1.5 million. Is that that's what we're talking about?
Yes, it is. And it says one time, but after talking yesterday, I think it's in the base. I think there was a something, so I got to confirm that, but it's 1.5 million, 3.5 gross in the base budget
For this year anyway.
for 2025.
Yeah, for the budget we're talking about. Okay. And that when that slide that had all the need, it was way beyond 15.
Oh, yeah, 15 beds versus there's a lot of.
Yeah, some kids.
Yes.
But that the idea of this is to bring all the kids that are out in the world back to Vermont. And that would be 15. Did I get that right?
Yes and no. So a couple things. One, it is 15 beds because this is, they put it in an RFP and the only response was Brattleboro Retreat, and they have a space available. So very little, if any, type of fit or whatever it's called, fit up
Yeah,
needs to be done, which is why it's 15.
okay,
And it would be a cross between bringing kids back and or placing kids in Vermont in their appropriate place for treatment. So that's why the hospitals are supportive of it, because some of the kids who could go to this as a proper place of treatment could be moved out of an ED or wherever they may be. It could be moving someone in hospital at Brattleboro Retreat into this. So it kind of is all of that.
so it's filling a gap.
It's filling a gap that we do
That's my
not have.
understanding is that there's this gap for this particular segment of youth that
Yeah.
need care
Yes,
that we don't have.
correct.
I think I got it.
Yeah.
Okay.
Is this one facility that they're gonna have?
Yeah, so it's
It's
15
not gonna,
beds.
okay, so it's not gonna be separated throughout
No,
the state?
it's,
Okay.
there's if you've ever been to Brattleboro Retreat, there's a
Campus.
campus and one of the buildings is used for this, for
So
15
the
beds.
building's there.
Yes. And it was remodeled several years ago. I don't know who was here, but, and then not used. But I think COVID hit and then, things changed. Melissa?
I have lots of thoughts on this.
I'm sure you do.
Number one, this has happened just in my time twice now, where we get sort of thrown at us this plan of we've got to do this,
Yes.
and this is a gap in care, which in my mind, I'm just like, what other gaps in care do we have that we don't know about?
Right.
Um,
You don't know what you don't
yeah,
know.
and it seems, why didn't we hear about this before? I mean, this sounds like it's been in the planning and in the works for a long time. Why aren't we just hearing about this now?
Okay.
I think because they found a building.
Just,
This has been around for a while.
yeah,
I will say, I want to, because I have concerns with the way it was presented in the budget,
Yeah.
right? I feel like it was there, but not really there, and it wasn't an open conversation. I would like to put that to the side
Mhm.
as more of a discussion that we have with DMH on, don't surprise us. We're good partners, come to the table. But I don't want that to be a bias on why we should or shouldn't do this.
and clearly we have this gap in care, and clearly there is a need. I just feel like the way it was presented to us and that it's almost like, oh, we have this facility that just, and it seems reactionary, and I hate to create for lack of a better word, it will be a sort of institution of type. I hate to create a level of care institution as a reactionary measure as opposed to a carefully thought out, just assuring that it's going to be a facility that meets the needs and frankly does no harm. I'm confused by some disparate testimony we received. The first time they were in here, I think we asked about, well, I know I did. Number one, how much are you spending right now to house these kids or to place these kids out of state? If we're moving them back in state, why aren't we using that money that we're paying to out of state facilities to be able to, fund this? And we were told at the time that it will cost more to have them in state than out of state. And that's why there was an additional in the base and additional, budget request was really to get this facility up and staffed.
Right,
Before they could move.
the
I
money,
understand that.
they need to be able to hire
Mhm.
before they can open. So they need, if we do this, they need the money to be able to do that. And then it would be, if we move people back from out of state, that the cost would move, but it could be kids that are in the ED, which That's a different
Yeah.
cost. So, and a lot of it then would go under the Medicaid utilization pot.
But then yesterday, they were talking about, they anticipated savings because they feel as though by moving youth back in state, they will, have more, sort of wraparound services, and it will be, clinically better for them. And that they won't spend the length of time.
The length of time, yes.
And frankly, they haven't told us, how much are they spending right now? I mean, how much is the state spending right now? I'd really love to know that number.
Okay. And I've asked for budget follow-up
Um,
after a meeting yesterday.
And also, we haven't really heard anything about the facilities where the kids are being placed now. Are they better than what we could do? I mean, granted, yes, they're not in Vermont, but what sort of care are kids receiving in other places? And is it better than maybe what we can do here, where we clearly have not experienced setting up a facility like this in the recent past?
Okay.
So I mean, but I recognize that there is a need, and I'm supportive of the need, but I also have all these questions,
Okay.
like, it's just seems.
Okay. Art?
Yeah, so the one-time money, do we know what that's going to?
So I believe it actually is base. I think that is a mistake. I need to
Okay.
verify that.
Okay, that's.
I need to
yeah.
verify that. And it would be going to setting up, so as we talked about with SVMC, right? In order to bring kids into a proper place of treatment, they need to do the hiring, set it all up. And so that is an upfront cost for that, which is why I thought it was one time. So I am, after yesterday's testimony, AHS is going to confirm with me whether it's one time or base.
Oh, base, okay, that's what
But
yeah,
overall, there is money in the budget, as Alyssa says, we don't know how much, because they're
Yeah.
they're sending
Yeah.
these kids out of
yeah,
state.
yeah, I gotta think that number is bigger than this number.
Oh, it's, yes, much bigger. Yes,
Um,
absolutely.
And so this is just a reallocation, and maybe
Yes.
we gain.
Maybe we can, maybe we don't really know. And I honestly don't think they know until
Yeah.
it's
Yeah.
up and running.
And the other question I had, and it kind of resonated throughout the discussion yesterday, you have kids with serious mental health issues. And then we presented the developmentally disabled. Now, is this place going to have both in that
So-
facility?
So that is, yes, I mean, the intent is,
Okay.
yes.
All
This
right.
is for a broad range of
Okay.
kids. Remember, there's a lot of youth and adults, but youth in this case, who have co-occurring issues, right?
Yeah,
And it's, what we heard yesterday, there's this case review CRC group that's made up of TCF and Dale and DMH and Vermont Family Network to make sure there's a family component in, to determine who goes and what the mix is while they're there. So it could be that there's a bed open and there's a youth that would be the proper place of treatment, but it may be decided that youth won't mix well with
Yeah.
youth that are there. And so a different decision is made.
and is all of this voluntary, or is there?
My understanding is voluntary.
It's all voluntary,
Yes,
okay.
yes.
All right, because do we have a place for involuntary for you?
It's Brattleboro Retreat, and that is the only one we
Another
have.
building that
Yeah.
they have, okay,
Yeah, and that is all we have for you.
okay.
Kelly?
One of the things that I felt, yesterday, and I was really appreciative of the testimony and also the questions that were asked, is I feel like, in my heart, I would like to see children back in Vermont. I get anxious when I hear about being sent to many programs. That's not there may be programs that are better and offering other things. And I don't think that takes off the table if that's the best and least restrictive environment for a child. but I would love to see more options in state that also allow have continuity of care that we need. And also when you institutionalize your child or put them in a hospital in that setting, in that, I think having access to them is super critical for healing and for having them to be able to reintegrate into their communities of homes. The other piece that Special Papa brought up yesterday was just like having this mixture of children and how important oversight will be and the screening and that planning time when they're placing children. And I'm glad we're going to hear more about that. So I'm leaning towards supporting that work and hearing what our partners have said, with the caveat is we have lots of questions that we need answered. And it will be something that I think we need to be very careful about, especially with children with disabilities being put in situations. Yeah, so those are my pieces.
Okay.
Thank you.
Mari and then Leslie.
I support this. I think we really need it. And I also agree with, I was talking with Alyssa yesterday about the question of why are we hearing about this now? And I really loved the work of the Vision 2030. And I think that's really important when you're talking about a whole system of providing mental health care that has so many elements that sometimes feel disparate. And I know the work on the ground, there's a lot of connections being made between the different elements of our system, but I would appreciate a conversation like the one that you mentioned about if there is more long-term or midterm planning, as was in the Vision 2030. Can you feel, keep us
Right.
in the loop on that?
Right, and maybe what we do actually is schedule DMH to come in some point this, second half of the, I'm just gonna say semester, whatever. And remind us what Vision 2030 was, right? And I think some of the language coming from Human Services is come back next year with, okay, let's look at the beds again. We've had a lot of things over the last couple of years, a lot of new programs, where are we? What's the vision going forward? So, yeah. Leslie and then Daisy.
One thing I didn't get was what's the turnover in these 15 beds? So how much accessibility does it really give us? Are they there for months, days, weeks? How does it really work?
That's exactly.
Yeah, and so that was I think that's information I love. I mean, they must know, right? Because they're sending kids out, but they know how long they're staying these other places.
Yeah, I mean, I think the question was asked yesterday and it just depends on the youth.
Yeah, so, but you could say it's
But
a
it's
week,
probably
so-
not days.
Yeah, weeks to months. So, adding 15 beds, what does it do for us in this gap? I'm
Right.
just trying to understand that. I think that for me anyway, there has to be, I heard Alyssa talking about Brandon and, or Woodside, I guess you were talking about, and, institutionalizing and that kind of stuff. I think I have, I come from that area, so there's some taking on faith that the Brattleboro Retreat will do a job that we respect. So I hope that that's true. They're doing it. We're believing in them in all these other ways. So I'm hopeful that we could believe in them in this way too.
And I think it was stated yesterday, though there were a lot of issues at Woodside, right? And we need to not repeat that. The PRTF is not for justice involved kids. So there is a difference there.
Okay, I wondered about
No.
that. That's what the
Not-
forensic facilities.
It's not, well, forensics facility is only for adults.
Okay,
This is not justice
all
involved.
right.
So Human Services is still working with the administration on, what we do with kids who were, formerly in Woodside or would be in Woodside and what happens. This is not justice involved. So DCF is involved because it could be foster children. So it's two different populations.
The thing that I really felt yesterday was for the parents and the families and how stressful and difficult it was for them to be able to manage the kids at home at that moment and that they needed help in that moment. And once they got help, hopefully able to move through and then be able to care for their children at home. So I'm hoping that my vision is right, that it is a, part of, you get admitted, you get treated, you get better, you move on, and that is what we're looking at.
Right. Chapa?
I believe that it's always better to have the kids close to home. Allowing the parents, et cetera, guardians, whatever it is, to be around when they're going through treatment. My big problem with this is mixing those most vulnerable people with somebody that is justice involved. And the concept is fine with me without them being involved. I just don't think it's a good idea to mix.
Yeah.
So I mean, I would actually vote against it if those kids.
If it was a
Be in
mix, right, yeah.
Yeah.
And so it was stated that they were not, that this is not justice involved kids. And remember, this is voluntary.
Yeah.
So that
But.
gives me faith that it can't be justice involved, but we could put that in our intent language.
Yeah, then I'd be okay with it.
I see, when we get the developmentally disabled folks, if they're involved with this, it seems to me, and I know nothing about this at all really, but it seems to me they would be in that facility for an awful long time. It is, no? I mean, I don't know anything about it, but do they physically get better with treatment? They do. Okay. I don't have a feel.
I don't know if all of them do, but I know of only one case right now that person is not going to get better because of the way the treatment is being provided. That person was fine before. Well, anyway, I don't want to.
Yeah, okay, no.
Yes, the answer to your question is yes, they do get better.
Yes, they do get better. Okay, then that's fine. All right.
But there's a limit to how far they can go too.
Right.
Yeah, and unfortunately, it doesn't matter if it's a mental health diagnosis, the developmentally disabled diagnosis, it's a physical diagnosis, and in all cases, you may or may not get better.
No, I understand. I'm just looking at longevity of staying there and are we in a situation, not that it matters, but because I think I generally support this, but where someone would be there for years.
Right.
And if so, then it's that, but I don't know.
Yeah. Daisy?
Well, I think that's one of the things that we need to understand is what services are going to be delivered. Is this a restorative space where people are going to learn their, activities of daily living and how to perform those better? And is this the only place and the best place for these youth to restore those abilities? Or is there a place that they could do it in the community? And I think Tamari's point about Vision 2030, that was all about an integrated and holistic system. And the Integration Council was sort of born out of that. So their last report, I think, was in 2022, the Integration Council's.
It was just a new one, I think.
So Leslie says there's a new one, but I
The
think,
Mental Health Integration Council?
yeah,
Yeah, there was one.
it came out of
24.
Vision. Okay, whatever. There's another report, but that was what Vision 2030 sort of gave way to. And so I think looking at those reports could be helpful for us. And I just don't understand how a facility like this is going to be voluntary on behalf of a youth.
But they're voluntary in other facilities out of state today.
I can't comprehend that with conversations that I'm having with parents who are parenting children who are in some of those facilities. I haven't come to that understanding. So I have questions about it. I also have questions about why Diva would be our lead here. That is strange to me. This seems like, Diva as a payer seems like a interesting choice for us to turn to when we have questions. I would want someone who is able to answer to more of the clinical operational practice questions that we have.
So I'm just gonna say Diva is the lead on the payer side, but Monica Ogilvy, the Medicaid director who's within AHS, has stated she's really the lead.
Medicaid,
Yeah, still
So,
Medicaid with,
payment.
with the groups of, yeah.
but payment. I mean, I'm thinking like someone who's actually in human services, like DCF or DMH, or, you know, one of the actual human services. Maybe she's clinical, I don't know, but regardless, I thought that was an interesting choice. And along those lines, that DSU wasn't at the table. And given that this, I think on the really wordy slide that we saw yesterday, the history of planning to this goes back decades. And yet still DSU was not involved.
Can you tell me what DSU is?
Department of Substance Use,
Thank you.
ADAP. So I have a lot of questions, but again, you know, like I said yesterday, there is a slice of our state families that need this, and I recognize that, and I want to just honor those families that want their children home. But my question is, what else are we doing in the name of Vision 2030 and the Integration Council to explore where else are we innovating in our system? Where else are we making equal investments so that these youth can, you know, restore their habits, restore their wellness in more holistic ways in their community with the support of their families? And how are we supporting those families to help them do that? I just wonder if we're making equal investments.
I think it's a good question. I mean, I think that's a very, very valid question, and there's, we need to talk about that. And I would say we're not making equal investments personally, but Leslie and then Topper.
Well, my only question is what happens if we don't do it to these families? We continue sending them out of state. Are we content with that? And we may be. Do we think this is a better plan for these families than continuing to send them out of state at this moment? Or do we wait a year or 2 years? That's sort of what I'm thinking about. As I said, I feel for these families and want to do what we can to heal these children and families. And I'm hoping that this is an opportunity.
Have you heard from families?
Hold on, Topper and then Mark.
When these kids turn 22, you're running into another
Yeah.
home. And that's what I'm trying to fix. So I would like to see a continuum of people that are in this situation. And maybe they go home after this. Maybe they go to one of those 3 projects that there's no money to fund right now. You know, those experimental projects. I mean, our system for dealing with these people is broken right now, and we've got to figure it out. If this is the first step, you know, have a place for people up to 21, fine, but we've got to also deal with 22 to 60. After 60, they seem to be okay. So I'm willing to take a shot at this. You might need more of these.
Right.
To do this thing, because there's a lot of people out there, right?
We have not heard from families, but we can bring the Vermont Family Network in, and
think
because
it'd be
they've
really
been at the
helpful to-
table. Yeah.
Even not just the network, but to hear
Yeah.
from an impacted family
Yeah.
member.
Yeah.
Up to 21 being.
Yeah, for this specifically.
Back to the money piece, because I'm like turning this all out in my head. It's a great discussion, by the way, but I'm going back to money. You know, I mean, it's my, people always say, how do we afford that? And my response is always, we're already paying for it. We're just paying for it. And, you know, I'm going through their slides again from yesterday. You know, they were talking about how this will create where we have a gap in care and it will loosen up the flow. It will make, I mean, we're already paying for these kids to sit in emergency departments. We're already paying for these kids to sit as inpatients at Brattleboro Retreat when that is not the level of care that they need.
Which means we're not
Which
putting
which
people
means we're
there.
not putting people there, which means we're taking the people who need to be there and we're paying for something else that they're in, which could be more or less expensive, depending. The only, the whole point of this is, I'd like to know like what they anticipate. They were talking about how right now they pay out of state, they pay like a room and board. So
Yes.
I would like to know, like, how does the room and board and how does their anticipated costs to care for these youth in this particular facility compare with what it costs to care for somebody in the inpatient setting at Brattleboro Retreat, what the daily rate is for a child to sit in the emergency department, kind of like a comparison of those costs.
Okay.
Because frankly, I think we're already paying for this.
We are. We are.
The other thing too, I don't know whether this is true or not, whether it happens. If you got a 15-bed facility, I'm wondering if Medicaid, the match comes in and they
Yes.
get more money.
Yes, for some of the things, yes.
Yeah, that's true.
Art and then Melanie?
Yeah, I want to go back to what Melissa said and what Daisy said. Believe it or not, Daisy, I'll go back.
We are a team.
You just said that kids are already at the Brattleboro Retreat in other capacities. See, what I don't get what we do, I guess. I don't understand the system enough to know. It sounds like, and Daisy talked about, she talked to parents who sound like you said queasy about something like this maybe, or didn't know where to turn with a child. Is that what you said, or kind of hinted at the beginning?
Yeah, who have been, who have had children that are bumping up against this need
Okay.
and then aged out of it.
And so a child has a mental problem of some kind. They go to the emergency department. They get sent to the Brattleboro Retreat now in a
So,
separate
The
facility.
Brattleboro Retreat, think of it as a hospital, right? It's hospital level of care. The
Okay.
Brattleboro Retreat is an inpatient hospital
And
for
they're
someone with a
not.
mental health illness. And so let me just finish real quick.
Yeah,
And so what Alyssa was getting to is sometimes they stay there longer than they need to because there's no step down for them. So think of, for an adult, think of it this way. You have an adult that is in an inpatient hospital for a mental health illness, and they're ready to be discharged, right? They've made progress, but they can't go home. So they go to Riverside. Remember, we did Riverside. They go to Riverside where they learn, skills and to get back acclimated into the community.
So when you say they can't go home, they're not mentally able to.
They're not ready
All right.
to go home. They still need help, but they don't need inpatient level of help. So think of a PRTF, and this is very general, as that step down for
All
a
right.
child versus the adult goes to Riverside. This child would go to what they're calling a PRTF. And my question is going to be, okay, we all know what Riverside is. Tell us how this is same, different for
Okay.
our children.
Okay,
That help?
this is a step down from what they've already been through. Maybe
Potentially.
emergency room.
Or they don't go to Brattleboro Retreat Inpatient Hospital. They go from the emergency room to a PRTF. So they
Right,
may not need hospital level.
yeah, right.
But they don't have this now unless they go out of state.
Right, okay, all right, so.
Melanie, and then we're gonna, sorry, keep going.
And then one thing that I think is good to bring up is if these children are stalled in hospitals or in highly restricted environments, they may not even be getting any education as well. Like one of the important piece of recovery is to normalize your life, is to keep going, to be able to keep up with your peers as much as possible to learn. And so for children that are just sitting in an emergency room waiting for a bed, they're not getting any education. And that is a really big part. So my hope is that at these other places that we can really make sure that the appropriate educational setting is also happening. So that they have that, because that is important for healing. And
Yeah.
I think that a 12-year-old, if they lose months of school,
Right.
it is just devastating on top of that.
And that's a really good point, Melanie, that we really have to drill down with them, because I know there is some troubles with that today and
Yes.
people getting, kids getting educated. So, all right, so we're gonna do Leslie and then Alan, and then we're gonna have a quick, maybe straw vote, and then take a break.
So I'm gonna continue on yours. One of the things they said was they needed to get, there's a moratorium on
Yes.
independent schools.
I know, we gotta talk to them about that.
Yeah, so that meant that they were thinking about education,
Yes.
which of course is crucial. I don't know what education's going on out in all the other places, and how does that
In
compare?
the emergency room, nothing.
Well, for
Right.
sure.
Right.
In Florida, I mean, the equivalent
Oh,
of
yes, yes.
that, you know,
Right.
are they doing it? Do they have educational programs?
Right.
So that was a concern of mine, how we get through that hump of the moratorium.
Okay. Bobby, I mean, sorry, Alan and then Bobby.
Okay, another thing, there's a cost for this. So the cost, 15 beds is not many,
No, and remember, these kids are already somewhere else,
and we're still going to need somewhere else to go.
right? But we're gonna need 15 less of those
Right,
potentially,
that's true.
or maybe not,
Okay, and
because
then,
there are kids waiting in the emergency room.
so we haven't heard of costs, and the other thing is, I think Topper mentioned this yesterday, but you gotta have some follow-up care.
Yes.
And I don't know, nobody's talked about how many staff members we're gonna need. There's a cost to this.
Right.
And I agree in the program, but I don't wanna,
So the cost in the budget right now, we're gonna hear more about the budget, but if we say to appropriations, we support this budget request. It is 3.5 million gross, 1.5 million state funds. That is the cost to do this. And then it will flow into Medicaid utilization. And when they come back to us, next year, we'll have a better idea of what we're seeing. But that's where we are right now. Bobby?
Well, it's real quick, just the independent school references therapeutic schools, right? Just making sure.
I don't know, I just saw it recently.
Okay, that's.
Yeah, we have to talk, we have to talk to them and understand it. It was in one of their slides. We did not get it to it yesterday.
Yeah.
And then we have to have a conversation with the
Okay,
education.
because that's a very different thing from
Yes.
usually people in independent schools. And then the other question is about what's appropriations gonna cut from what other recommendations we've made if we approve this.
Right.
That's my biggest worry too.
They may very well.
So they may, that's a really good point. And we may not get anything approved, right? So again, it's one of those things. Remember, we prioritized things in buckets, right? We had the one-time funding and then, so, I can't answer that question.
Okay, it's just, that's what I worry about, because because it's in the government recommend doesn't mean, it's not gonna be protected. Or the other things that we recommended are gonna be
Right.
protected.
Nothing's protected.
Yeah.
There is, I'm gonna be very clear. There is very little to no money. So I think we can assume that a lot of our stuff is not going to be funded. But I still think we need to put forward what we feel as a policy initiatives are important. Yeah.
Thanks.
Yep. Okay, so I'm hearing, and we don't have to do this now. We can come back. I want to give everyone a break though. I am hearing that we cautiously are saying, yes, this is a need our state has, and we still have a lot of questions. And so I'm thinking we put forward to appropriations tomorrow when the three of us go in, that yes, we are supportive of this, and we are going to continue taking testimony, and we will be providing language around either expectations, intent, or what they need to come back to with us for a vision and how this is all working within the system and a continuum of care. So I see a lot of heads shaking. So I'm going to say we're going to take a little straw poll on this. And don't feel pressure to agree. If you don't agree, don't agree. And then we'll see where we are. And if we have to come back and talk more, we can. So all those
Before we do that.
Yeah.
I want to make one thing very crystal clear. And we may not be talking about the same individuals now, but I'm going to go back to what I've been saying for years. When Brandon Training School closed, we promised people that these services would be provided locally. That was the promise we made to them. And Brandon's, that's what allowed Brandon Training School to really close, because we promised. So it didn't mean just the kids in Brandon School.
Right.
It meant kids that are coming on after too. And this is what we're talking about now. But we still haven't lived up to our promise to the kids that were in Brandon Training School, that are calling us now. Their parents are calling now, saying, what the hell is going on? So keep that in mind. This is a population of very vulnerable people. Some of them can't even speak for themselves. A lot of them can't. So they have a guardian that does the voluntary thing to get served. So anyhow, that's
Okay.
my piece.
Okay. All right, all those in favor of us telling appropriations that we are tentatively saying yes to this, we're gonna keep taking testimony, and then I can hear from appropriations of when we have to give them a definite. Everyone, okay. All right, I think we need to give you some weights to build up that arm a little bit.
No, my only hesitation is kind of what Bobby said. And I support it wholeheartedly, but there's money somewhere that could pay for this that's hidden in transportation for the kids and all the costs. I guess we'll recoup them, but I get nervous
I know.
about that recouping, quite frankly,
I know,
in the state government.
I hear you.
But
Great. All right, thank you. That was a great conversation, and I am going to let our friends who were with us yesterday know that they should be listening to this conversation before they come back in and testify, because we just asked a lot of questions that they should come prepared to bring to us answers.
So they should watch.
They should watch this. All those who are listening. Okay, we're going to take a break, and let's come back in